没有关系，如果有问题私底下我们都可以再讲。那我们现在就准备开始上第二堂的课。
包在他的那个包在那个对上面，对不对？我也听到对，这样就说很热，然后就有嘛。因为诊所不会这个问题，诊所常常包。所以其实没有比较重要。
Okay. Shall we start? Okay, I'll talk the next topic. Ultrasonic scaler for pocket management. I will discuss about how ultrasonic scaler are useful for periodontal treatment. Very often this topic is discussed among professionals, hand versus ultrasonic. I will introduce one interesting study from Gothenburg. Professor Jan Benstrom was my responsible teacher. He was a chief professor next to Jan Linde, but retired some years ago. 41 patients with moderate to severe chronic periodontitis is examined. They're having on the average 35 periodontal sites with more than 5 millimeter pocket. Following oral hygiene instruction, two randomly assigned to two different treatment groups. One is the test group. This is a single session, 1 hour, full mouth subgingival instrumentation using ultrasonic device. It means one appointment, 1 hour, only the ultrasonic. At that time, they used the EMS systems. Okay, again, one appointment, 1 hour, and only the ultrasonic scale. As a control group, quadrant scaling and root planing with hand instruments with 4 or 5 appointments. They use a hand scaler and they need 4 or 5 appointments, okay, with the root planing, traditional root planing. After 3 months, residual pocket more than 5 millimeters were treated again. And let's look at the result. Bleeding or probing did not show statistical significance between both groups. And also changing of attachment level did not show any difference. In this study, a percent of closed pocket after 6 months was compared, but no difference. And also we can see the instrumentation level from this figure. For example, please look out to the here. More than 7 millimeter pockets, about 50% is closed. What do you think? In my impression, the therapist has so good skill. I asked my colleague by email, who did this treatment? And I found that operator was my instructor. She's the well-experienced dental hygienist. I don't know, my dental hygienist can do the same result. 50% of more than 7 millimeter pocket can close less than 4 millimeters. That's well experienced. But please be careful when you use this study in your clinic. In this study, both groups were well controlled of plaque after treatment, less than 20%. Less than 20% means that when you see the patient, you must feel, oh, this patient is brushing well. Yeah, good plaque control patient. Only the difference was treatment time to make result. Ultrasonic instrumentation is more quicker to treat. This is the photo of Professor Jan Benstrom. Actually, during my stay, he never smiled. But at the graduation, he smiled at last. But he's very smart. I think more smart than Jan Linde. But he's not so active now. Okay? Not only this study, but also other clinical studies comparing between hand versus ultrasonic showed similar result. All studies did not show statistical significance in clinical results between hand and ultrasonic devices. Please look at my clinical case. Wow. She was 42 years old. Her chief complaint was bleeding gum with swelling. Of course, so far, no regular checkup. Different from first case, molar teeth were remained, and this side also. Deep pockets were observed in many teeth. I could not do probing in lower front teeth because of heavy calculus. Yeah, you must see sometimes such a case. All teeth were fixed with calculus. Okay, natural fixation. If all calculus are removed before fixation, it is a little difficult to handle. So this is also a clinical point. Only calculus in contact point was removed by cavitron at first. Then we put the bonding material for fixation. And after that, fixation with bonding material, all calculus were removed. After oral hygiene instruction, I would say again, this is most important to make a good oral hygiene. My dental hygienist did scaling and debridement in one day with cavitron only. This is after first instrumentation. She did not use hand scaler because much bleeding will disturb the instrumentation. Fortunately, this patient brushed her teeth so well. Right side and left side. We can see some residual calculus around here in upper molar. Of course, we should remove it from plaque retention point of view. This is probing chart after first instrumentation. Still, we can see some pathological pocket in 1.4, 1.5, and 2.5. They were treated again. Retreatment was carried out with a combination of ultrasonic and hand scaler. 2.4 is extracted after this. During the re-instrumentation, I started to fix upper teeth because hypermobility and patient claimed chewing discomfort. On the right side, from 1.6, I made a temporary crown and making a bridge like this to the 2.3. This is final chart. Still remaining pathological pocket on 1.4, 1.5, and 2.5. I think we could maintain because those sites were not difficult to access and the plaque control level was so nice. And this is final. Yeah, right side, sorry, there is a Gaussian, I'm sorry. The left side. And this is final examination. Yeah, we have some remain, but I think I can maintain. Now we are maintaining for 1 year. So, I'll talk about dental implant therapy. What's happening in the world? I don't know in Taiwan, but in Japan, we are now facing so many trouble after implant therapy. To be honest, I don't have so much trouble of implant in my case. This is mainly due to the case selection. I never do complicated case and choose a good plaque control patient only. But this patient came to me some years ago. 10 years before coming to my office, her dentist did the implant therapy for her. During 10 years, no regular checkup. But she has been felt uncomfortable for chewing left side. Taking X-ray photo, destruction of bone around the implant, and root fracture, and also a secondary caries here. Cutting a bridge, fixture was dropped out. The surface of fixture is contaminated and with bad smell. How often can we see such a trouble? I will just introduce some epidemiological studies. This is published from Gothenburg Group. Perio and Broadmark team collaborated for this study. The patient is picked up from Broadmark Clinic. They are after 5 to 10 years after implant surgery. 3,413 implants in 660 patients were examined. The prevalence of peri-implantitis, the patient level 27.8%, that means the number of individuals. And the implant level, that means number of fixture, 12.4%. In year 2008, Dr. Zitzman and Dr. Berglund analyzed previous studies as a systemic review. Actually, I had a date with Dr. Zitzman before, 20 years ago. She is so nice. A peri-implant mucositis, they estimate that patient level was 80%. I mean, the 80% of implant-treated patient has inflammation in mucosa. And implant level was 50%. And the peri-implantitis patient level was from 28 to 56%. And the implant level, it was from 12 to 43%. They have a variation because each studies have different criteria. How is in Japan? This data is not published, but Dr. Ogata reported the prevalence of peri-implantitis. It was reported in the meeting of Academy of Periodontology of Japan last year. From 34 dental clinics in Japan, 986 implants in 267 patients were examined. The implant was before more than 3 years. In patient level, peri-implant mucositis was 33.3%, and peri-implantitis was 9.7% in implant fixture level. This data was reported in the newspaper as sensational news in Japan. But this is the data from a clinic of Academy member, not randomized data. Each epidemiological studies takes different criteria, so we don't know exact data. But anyway, only things we can say that peri-implant disease is not a rare disease anymore. It's not rare. But you must have the next question. Can we stop the progression of disease? In this year, Dr. Hiroka in Japan published an excellent textbook about implant therapy in periodontally compromised patients. Actually, he was my boss. He was my boss. And the first student graduating from Gothenburg University. And I worked at his clinic for 5 years when I was young. Definitely, he must be one of the best periodontists in Japan. I have to say this comment because he asked me to call in Taiwan next year. Okay, and this is his case. And the patient was 45 years old from England. Implant therapy was done in Norway some years ago. He found deep pockets around the implants. clinical examination and X